Hello, everyone, and welcome to another episode of Fertility Docs Uncensored. I am one of your hosts, Dr. Carrie Bedient from the Fertility Center of Las Vegas, and I am joined by my two seismically sensational co-hosts, Dr. Susan Hudson of
Hello.
Texas Fertility Center and Dr. Abby Eblen of Nashville Fertility Center.
Hey, everybody.
I
Hi
don't
there,
think I've
too.
ever been I don't think I've ever been
But
said that I'm
describe
seismic.
I mean, you guys are as
it's like
important as volcanoes.
as an earthquake. Okay, we're seismic like earthquakes and volcanoes. Okay, I got it now.
Yeah.
I was
I
thinking more
mean,
like
your
size, like big
forces,
size.
you are forces of nature.
Okay,
Ah,
there you
I
go.
like being a force of nature.
Been a lot
Yeah.
of forces of nature
And
around
I
lately.
don't think
Yeah.
anybody could deny that both of you are forces of nature. How's summer? What's new?
I
You know,
am
it's
Go ahead,
Go
Abby.
ahead. I was just gonna say it's so fun being outside, being in the warmth. I'm one of those people that I really do like light. I don't think I have seasonal, dysthymia or seasonal depression or whatever, but I like the sun, I like the warmth, I like the light. I just like hanging outdoors. Now, I do wear sunscreen because my skin is very fair and I know I need to do that, but I really just like being outside. I like to walk outside, I like to garden outside. It's great being outdoors.
I like sitting on my back porch during the summer. Like we have this nice little setup and it's comfy and we have little couches and you just can like sit there and prop your feet up on the table and just relax. And I've got a wonderful backyard where I have lots of trees and just especially when it's breezy. When it's not breezy in Texas, we have ceiling fans above us so we can pretend there's a breeze.
You make it breezy.
We make it breezy.
I love sitting on my back porch as well. We've got a patio upstairs, and we live in kind of a wind corridor because we're right next to some mountains, and so the
Oh
wind
wow.
channels down, and so there's usually a pretty decent breeze. And
Oh,
I
that's good.
sleep out there in the summertime sometimes, especially when my husband's on call and not at home, so I don't get flack for not sleeping in our normal bed. But it's so nice, and I love there's a certain set of popsicles that I think are so delicious that come out in the summertime from when I can get them. And so I eat those in spades.
So what are these
Yeah,
pop?
what are they? Tell us about the popsicles.
So the brand is called Melona, Melona, and the ones that we have at Costco, because Costco is the maker of all things great and wonderful, they sell this pack where it's coconut, mango, and melon.
Ooh.
And the melon ones are my favorite. They are also the favorites of other people in my house, and so I may or may not have taken to pulling a couple out of each box and putting them in like a frozen vegetable bag. Um, to make sure that I get at least a couple.
Oh,
But
that's a good trick.
yeah, but they're all so good, and they make me think of summer. And so there are some times when if I have any that like spill into the winter, I'll eat them in the middle of the winter and pretend that it's the middle of summer.
Which is not too hard if you live in Las Vegas, right? For the
No,
most
it is
part.
not too hard. Although I mean, it can get cold enough to snow here
Yeah.
and be miserable. But at least it's sunny, and so it's not the cold and gray that I was used to in residency where I lived in the, Midwest. So
Yeah.
That sounds yummy.
yeah, it is. Okay, popsicles aside, which now I know what I'm going to do right after we're done recording. Um, what questions do we have today?
All right. So our first one is I had 4 pregnancies and 4 live births via C-section. I just had a tubal reversal after having my tubes tied for 8 years. Recently diagnosed with PCOS and insulin resistance about 2 years ago. My periods are back to normal and very regular. My only worry is, am I ovulating? I used to know because I would get the long egg white discharge, but since developing PCOS, I never see it anymore. During ovulation, I just get very wet, watery discharge with some cramping. Can I still get pregnant without egg white cervical mucus? How will I know for sure? Also, I've read that tubes can heal closed within 6 months of tubal reversal. How true is this? What are the advantages or disadvantages of HSG? Thank you, ladies, and I appreciate you so much.
So I'll answer the tubal reversal question. So if a tubal reversal is done really well, it's not going to heal back together in 6 months. I mean, when we do tubal reversals, we put a little catheter or usually some sort of guide in there so that when we sew the tube together, and usually we do it in 2 layers, generally it doesn't heal shut. Now, we'll say, and I always tell patients this, I mean, there is a chance definitely that one or both of your tubes may heal together because that opening is so tiny. We use microscopic suture that you can't even see with the naked eye, and sew it together. Most of the time, you get a pretty good result. If the tube is of normal length on both sides, you get a pretty good result. But I definitely am in favor of doing an HSG. Usually I tell my patients about 6 months after that, it's wise to do an HSG because, you want to know if your tube is open, or if I would say tubes are like kidneys, it's great to have two, but you only need one. But if you only have one that's open, it's less likely that you're going to be able to ovulate on the alternative side and still get pregnant. So you kind of want to know which is your best side if you only have one open tube. So Carrie, I'll let you follow up with the other part of the question.
Say I always worry about tubes that have been repaired because I worried about the internal scarring and the destruction of the cilia, the little hairs in there. Because no matter how good of a surgeon you are, there is inherently damage there because there was damage when the tube was blocked in the first time, and there's at least a little bit of damage when they take out that area and put them back together because the tubes aren't a uniform like PVC pipe all the way through. It's wider at one end, narrower at the other end. And depending on how much you have to take out in the middle, sometimes you're trying to attach a small end to a bigger end, and that doesn't always work out super well. When you're looking at whether or not you can ovulate without discharge, so bodies are allowed to change. What you see is allowed to change. How your body reacts to certain hormonal changes can vary throughout the years. And so yes, you still can ovulate. Now, for you in particular, because you have been so attuned to what your body is doing and what has been normal for you, I do kind of worry that you're maybe not releasing an egg consistently. I think that that's worth following up with some tests, even if it's just a progesterone level on day 21 to 24 of your cycle to see, have you released an egg? That doesn't tell you if you're going to release an egg every cycle, but at least lets you know, are you doing it? Because if you're releasing an egg and you're not seeing the egg white discharge that you have historically seen, then that can give you a little bit more comfort of, okay, my body has changed. This is showing up differently now than it did 10, 15 years ago. And so I know that I can still be ovulating because I'm still having regular periods. So the answer to that is yes and no. There's some relatively easy tests that you can do, day 21 progesterone levels. There are some of the at-home kits that you can use for monitoring that are helpful. They're not foolproof, but they can be helpful. So things to think about.
Very good.
And one other thing I was going to add to that too is with tubal reversal, a lot of times time matters for men when they have vasectomy reversals. For women, it's not so much the tube itself that's the problem, it's the age of the patient. So, I know you've had 4 children, and that's you probably not have one child a year. I mean, it's probably been over a span of time. So your age is something to consider as well. So if someone has not already done this, it may be worthwhile for you to have an AMH or an egg count to get some sense for kind of where your egg count fits on the reproductive spectrum.
Good stuff. Good stuff. All right. Our next question is, I've been told that I need to start a statin. I would like to try to get pregnant first and worry about starting a statin postpartum. Would my cholesterol increase if it is already elevated, or would it stay the same? What are the risks associated with very high cholesterol in pregnancy? I lost weight and my cholesterol actually increased, so I don't know the natural methods of decreasing cholesterol are going to be effective regardless of effort spent. I'm in the process of seeking a second opinion because I know that once I start a statin, that will be the end of our options aside from surrogacy. I appreciate any insight to cholesterol and statin alternatives safe in pregnancy. So
That's probably more an internal medicine question than it is an OBGYN question. I mean, it sounds like she needs statins, but the simple answer for us, if somebody comes to us on a statin, and I think you've been told this, that you can't really take a statin when you're trying to get pregnant because it inhibits production of cholesterol, and cholesterol is the building block for estrogen and progesterone and all the hormones that are necessary for reproduction. So really that would be a better question probably for your internal medicine doctor. I don't know what your weight is, but weight is always a big factor. Not all, the only thing, but a lot of people who are on statins and have high cholesterol may be heavy. You can't outrun your genetics, though. You may be skinny as a rail and do a lot of exercise and still have really high cholesterol. So that is something that would be something you'd want to discuss with your primary care doctor about risk for you and whether or not to stop it.
It's normal for your cholesterol to increase during pregnancy. We know this because We actually encourage people, if they're getting life insurance during pregnancy, to make sure that whoever's either getting the life insurance through knows that they're pregnant, because it is normal for those cholesterol levels to be elevated. And again, just like Abby said, you really can't be on statins, because cholesterol is the building blocks of pregnancy, and the creation of embryos and fetuses and all that kind of good stuff. So I would say really, have a good sit down conversation with your internal medicine doctor and say, hey, listen, we're actively trying to get pregnant. Can we manage this without a statin for the time being? And then as soon as I deliver and, moving on to that next phase, at that point, getting onto a statin. I don't think that there's any issues with being on a statin postpartum that should cause any issues. Thoughts, Carrie?
When you're thinking about statins and what they're designed to do, they're a little bit different in that they're more of a preventative medicine, because when you think about someone who has a seizure disorder, for example, the reason that they are taking medications to stop seizures is so that they don't have a seizure now, as opposed to any sort of preventive effect for the future. The reason that someone takes a cholesterol medication is usually not because they're imminently gonna have a stroke, for example, or a heart attack tomorrow. It's more because in 20 years, you want to minimize their risk. And part of the way you do that is you start when they're, 35, 40 to prevent that. And so it puts it in a slightly different class. So your doc, your internal medicine doc may be a little bit more amenable to saying, yeah, we can hold off for another year while you get pregnant and do this. There are some people who have genetic cholesterol disorders that are extraordinarily scary. That is
Mhm.
a different ball of wax, but that's something that you and your internal medicine doctor need to talk about, because particularly if you're especially young and you've got crazy high levels, that is a different story. And that's something that is well worth having internal medicine weigh in on before you get pregnant anyway.
And when we're talking about cholesterol in general, I think we sometimes throw in triglycerides. And oftentimes triglycerides are the one things that can make us, like, your LDL and your HDL
Mhm.
and your total cholesterol, like those are different types of cholesterol, and those tend to have more issues with longer term risks. I think the number that tends to get most physicians nervous about acute or immediate things happening is high triglycerides, because really high triglycerides can increase your risk of things like pancreatitis, a severe
Mhm.
inflammation disorder that can happen in your pancreas and can be very dangerous. And so if you're dealing with triglycerides, also talking to a nutritionist can be very important. Triglycerides do tend to be very, very diet mediated. And even though you may have, worked on weight loss and different things like this, what is actually in your diet, if it is your triglycerides, I don't know that, but if it is your triglycerides, you may have to follow a relatively strict diet when it comes to certain types of foods to help minimize the risk of those high levels in your bloodstream.
If they draw your blood and it's white instead of red, that is a very different situation than what most people have to deal with. And yes, this is actually a thing. They can do that when you've got some of these severe, especially triglyceride disorders. But fortunately, most people don't have to deal with that.
Hey, and remember, HDL is the good cholesterol. So every now and then people will come and go, oh my gosh, this HDL is really elevated. Well, that's actually good because it's protective. So
Yes.
You can actually have high total cholesterol because of high HDL.
HDL.
That's okay. That's okay. The whole thing is looking at the big picture. And so that's really, I think, what we're trying to say here.
Yeah. All right. So today we are going to go back to some of the very beginning building blocks of fertility treatment and some of the things that many, many people have heard about. And they come into our offices asking about, of, hey, can I do this? Because I've heard it's the simplest, the easiest, all those things. So it's a set of simple medications called Clomid and letrozole. And so
Or
let's
clomiphene.
or
Clomiphene is generic.
clomiphene. I was just thinking about that. So it's clomiphene and letrozole or Clomid and Femara, depending on if you're going by the generics or the brand names. So let's start with Clomid. Tell us a little bit about Clomid and what it is and how it works.
So Clomid has been around for a really, really long time. I think it's probably the original fertility pill. It was introduced, I think, and I may be wrong about this, probably around the 1940s or 1950s. Do y'all know? I think it was around that era.
I think it's been available in our country for close to 60 years, almost 60 years. So yeah,
That'd
that's
be about
about
right.
right.
That'd be
About right,
about
yeah.
right.
Mhm.
And so it's an oral medication that you take during a certain phase of your menstrual cycle, usually shortly after you start your period, usually on either day 3 or day 5. There's nothing magical about those days. A lot of it depends on how your clinic works and what your doctor believes in. And it is meant to help recruit follicles, the little houses on your eggs, houses of your eggs on your ovaries, when ideally your brain and your ovaries may not be communicating effectively with each other, or to help recruit extra follicles.
Okay. And so, oh, go ahead, Abby.
I was just saying, and letrozole, I'm guessing you're going to ask me about
Yep,
that.
that's the next question. You can read my
So
mind.
letrozole is pretty similar. It has a little bit different mechanism of action and inhibits an enzyme. And overall, the end result is low estrogen. And it's a drug that's not approved for the use for which we use it for. So, but for about 15 years, probably in this country, we've used letrozole for ovulation induction, trying to make an egg or two on you. But primarily, it's approved. If you look up the drug online, it's approved for use for breast cancer, which sounds really, really scary. So we always tell everybody the key with this drug is what it does is it keeps your estrogen level low. And if you're a postmenopausal woman who's had breast cancer, that's what you need. You need a low estrogen to decrease your risk of having recurrent breast cancer. If you're a young reproductive age woman and somebody turns the thermostat and changes your estrogen, all of a sudden your brain senses that and says, something's up, something's going on here. So it forces your brain to produce more of the hormone follicle stimulating hormone, or FSH. That's the hormone that goes down and stimulates egg development, and in the process increases your estrogen a little bit and helps your lining. So that's kind of ultimately, it's very similar to Clomid in its mechanism, or in the end result, it's a little bit different in terms of the mechanism of action. The other huge advantage for letrozole, and I think why a lot of us tend to use it more commonly now than we use Clomid, is just because it tends to have less side effects. It's rare, rare, rare that I have a patient that comes to me and says, "Oh, I had this terrible side effect from letrozole." Most people actually feel pretty good on it. I mean, there's every now and then I'll have people that'll complain of some joint pain from it, but that's pretty rare. For the most part, it's really well tolerated. It's taken at the exact same time in the cycle as Clomid is.
So a little bit about side effects. I would say the most common side effects I hear from letrozole are sometimes it makes people tired. So I generally recommend taking it in the evening because might as well sleep through the tiredness. And you can have some issues with some hot flashes. However, those things do tend to be less severe than those side effects from Clomid. So side effects from Clomid, um, hot flashes tend to be very predominant. Most people have some of those. Some people can have some mood swings. And if you do have mood swings, if you ever, ever, ever have thoughts of hurting yourself or hurting somebody else, please tell somebody who can help you get help right away. Okay. That is not common, but anybody who has mood swings, that is always a very small possibility. On the fertility standpoint, the negative side effect is, especially if you're using Clomid for repetitive cycles, so going from cycle to cycle, just trying Clomid at home on your own, it can actually make the lining of your uterus thin, which may make it not quite as hospitable of an environment for an implanting embryo.
And what can happen at home when you're doing repetitive cycles? What are the things that you need to be mindful of when you're going into the next cycle? So you just finished one cycle of Clomid, you have a negative pregnancy test, you're about to start again. What are the things that you need to kind of at least know are potentially possible?
So these medications are really kind of pushing your ovaries to kind of overperform in a way. In other words, it's trying to push your ovary to make one and maybe two eggs. And so, as Susan mentioned before, that the sac around the egg is called the follicle. And so sometimes, and particularly people that maybe their reproductive axis is a little unusual, like people with PCOS. It doesn't respond quite the way maybe it should. Thermostat's a little too high or too low.
When Abby's saying reproductive axis, she's saying that your brain and your ovaries are not communicating effectively with each other.
Correct. Yeah. So ultimately, sometimes your brain gets a little overactive and produces a little too much of the hormone FSH. And so sometimes what can happen is your egg starts to grow in this sac, this follicle, and maybe it gets really, really big before the egg can pop out. Or ultimately what can happen is you can have a cyst on your ovary. And we have a whole show about cysts because people ask us a lot about those. These kinds of cysts are really normal physiologic cysts that may have hung on a little too long and are a little too big. And so some people can have pain related to that. That's really probably the main symptom. And so if you have pain right around the time of your period, or if you don't, sometimes if you don't start your period when you think you're supposed to, it may not be pregnancy. It may be related to a cyst on your ovary. So anytime you have those types of symptoms, we want to see you and we want to diagnose those. And probably what we'll do if you have a cyst on your ovary is just have you wait a month or so, bring you back again and just double check. And generally those types of cysts that are from a normal process that have just gotten a little bit too big, they'll go away over time. And usually within one cycle, after you sit out, we can, see you back, make sure you don't have a cyst there and restart you again with that medicine.
So one thing I wanted to kind of bring up is if you're using Clomid or letrozole in the hands of your OB-GYN, as opposed to in the hands of a reproductive endocrinologist, you may have a little bit different experience. And so you need to be aware of certain things if you're doing things with your OB-GYN. So if you were to do these with your reproductive endocrinologist, most of the time you're going to get a baseline ultrasound to make sure that you don't have any of those cysts that Abby's talking about. Okay. And oftentimes we do what we call follicular ultrasounds or ultrasounds of your ovaries looking for follicles to make sure that you're responding appropriately and actually responding to the medication. So when you're doing this with your OB-GYN, it is not uncommon for you not to get the ultrasounds. So when you take these medications, and specifically if you are anovulatory, so you don't have ovulation every month, you don't have periods every month, you have something like PCOS, polycystic ovarian syndrome. So you take the medications, and then at the point, that you should be having a positive or negative pregnancy test, you're not having a period. So there's multiple things that could have happened. One, you might have one of those cysts that Abby just described to you. But another thing to be aware of is that you may not have been on the right dose. Okay. And so if you did not recruit a follicle and ovulate, then there's nothing to make you have those hormonal changes that make you have a period. And so being very aware of, okay, I'm at this point in my menstrual cycle, I should have ovulated and I should have a positive or negative test. There may need to be manipulations of your dosing. And so don't just take 50 milligrams of Clomid, not have a period. They give you Provera or a medicine to make you have a period, and then do the same thing over again with the exact same dose. That from our standpoint doesn't make sense. Another thing to kind of know, and this is with letrozole or Clomid, if you're doing this with your reproductive endocrinologist, they may do that ultrasound and be like, you didn't respond. You don't actually have to have a period to go up on your dose if your lining's thin and nothing's happened. I mean, we used to kind of practice that way, but that I think has gone the way of the dodo bird. And so we can just bump up your dose and get you to the right dose that you need. Thereby we're getting to you there quicker. So there are some nuances in what's happening between the brain and the ovaries and the interaction with either of these meds that if you're having ultrasounds, it can facilitate you getting where you want to be a little faster.
One other point I thought you might make too is sometimes, depending on the physician and the way they were trained, sometimes they'll start you on one pill of Clomid, and then if you don't ovulate or think you don't ovulate, they'll go to 2 pills, and then sometimes they'll go to 3. I really think to me, that's a little scary. I typically don't do that. I really want to make sure and figure out what dose you do respond to. And once I find a dose that you respond to, I really feel like it's best to keep you on that dose for all the reasons we've just described, because You can have more than one egg that develops, and that can increase your risk of multiples. And everybody kind of laughs about that, but we really don't want you to have multiples. It also can increase your risk of cyst and things like that too, if you're on a higher dose than what you really need.
Another thing to know about letrozole versus Clomid is that there's actually our recommendations nowadays are if you're anovulatory, letrozole is probably the preferred method. And in addition to being more effective, it does have a little bit less risk of multiples as compared to Clomid. So as Abby said, our goal is always ideally one baby at a time. And so it seems to be a better option in a lot of situations nowadays.
So what's the effectiveness of using Clomid or letrozole? And before we can really answer that, we need to kind of go back to who is an appropriate person to use Clomid or letrozole on, in order to have, reasonable expectation that this might work and they might help get pregnant for it. So who's a good patient to use Clomid or letrozole on, and who is not a good patient?
Well, I mean, really, we use it on a lot of people who do ovulate, but really, really the intended target initially was for women who don't ovulate regularly. And the data really has shown for a long time, particularly with Clomid, and I'm not sure if we have a lot of data letrozole, but I assume about the same. About 80% of people will ovulate on at least one pill, two pills, or three pills of Clomid. So it's pretty successful in helping women ovulate. And if somebody comes to me that has an ovulatory problem, I usually say that's my favorite problem to have because that's the easiest problem to fix. And so most women, if that's your problem, we can get you to ovulate usually with oral medicine and not have to go to something more aggressive like IVF or injectable medicine.
So when you're also talking about acceptable candidates, your tubes need to be open, at least one of them. We need to have sperm. So, I mean,
That's
I always
important.
think it's a good thing to get a semen analysis a lot, even if your partner has had children before. It
That's
doesn't
right.
mean things haven't changed. Um, let's see, other people that it would be important to kind of minimize. So if you do have a special type of anovulation called hypothalamic amenorrhea, these medications usually are not going to work. You're going to be the people who have to go straight to injectable medications, which in this day and age is a very small proportion of people to do pure injectable medications. But hypothalamic amenorrhea is one of those that you're unlikely to be able to ovulate using the oral medicines.
And usually, really translated, what that means is IVF. We really don't use just pure injectable fertility drugs anymore. We used to do that and do insemination. But many of us over the years have had patients that have had more than one baby, and we've learned the hard way that that's not a great idea. And actually, data published or a meta-analysis done by ASRM looked at that and really showed that using injectable drugs for the majority of patients is not helpful in terms of pregnancy, but it just dramatically increases the risk of more than one baby. So we typically don't use that much anymore. So that would mean if you don't respond to Clomid or letrozole, and you don't ovulate well, IVF would be the next step for you.
So I just thought of another thing. So when we're talking about other appropriate candidates, so again, we've talked about people who don't ovulate. Those people who are ovulatory, who have normal periods, signs of ovulation, those types of things, using ovulation induction medications with insemination, that combination does increase your pregnancy rates. But just taking ovulation induction medications in the absence of insemination, if you're ovulatory, probably is not going to increase your chances. So, it's one of those things that we often have people who are like, oh, can you just give me some of the oral medications and we have intercourse? We can, but it's probably not actually improving your odds. And so it's really the synergy of having a couple of follicles, maximizing egg and sperm interaction with the inseminations that enables us to help improve your chances of pregnancy for a woman who is ovulatory.
So once you have a candidate who's appropriate for this, what kind of success rates are we talking about here?
I was thinking the same thing when Susan was talking success. So
Yeah.
it's all relative. So if you've tried to get pregnant for more than a year, and this counts for people who really are not trying, but are not using birth control and having sex, and there's egg and there's sperm and there's a uterus available. If you have been trying to get pregnant for a year or more and have not conceived, you have about a 1 to 2% chance per month on your own. Your overall success, if you have never tried before and you say, what are my chances? It's really dependent upon age, but if you're, 18 or 20, the peak of fertility is about a 20 to 25% success rate per month. If you're in your 30s, it's more like 15%, somewhere in that range. So if you've tried for more than a year and you can't get pregnant, about a 1 to 2% chance on your own per month. If you use oral medicine with insemination, about somewhere around 10% chance, give or take a little bit, depending on your age, per month per
As a
try.
as a general guideline, and I think this is a good way to kind of break it up with age, is if you look at a chart of what your natural chances of getting pregnant each month per year is, and you look at that chart, and so like if I'm 32 and what are my chances of getting pregnant in the first year of trying each month, we are attempting to get you close to that natural fertility rate, or what we call fecundity rate. We are not usually going to be able to match it. We can get relatively close, but obviously that changes with age. And the only thing that we're going to be able to do to really surpass that safely is going to be looking at things like IVF. And again, IVF's the right thing for some people, it's not the right thing for others, but we are hoping to get you close to what your natural chances of pregnancy are. We're not going to likely be able to supersede those without doing something beyond Clomid, letrozole inseminations.
Yeah, that's a great point, I think.
So when you have someone who comes in who is 43, 44, who says, look, I want to do the most minimally invasive, involved thing possible. Can you just give me Clomid? How do you think about those patients? How do you respond?
Well, I think the doctor and all of us would, be thinking, oh my gosh, at 44, your egg quality, the genetics of your eggs are really, frankly, really poor. So some data has said if you're 42, you have to have something like 24 eggs, like 2 years worth of eggs to have only one that's normal. And so if you are talking about that, if you're talking about genetic issue, which is the biggest issue in women over 40, that's probably inhibiting their fertility, if you do something like this that bumps their chances up a few percentage points, it's probably not going to be all that helpful. It's probably, honestly, you're probably going to be wasting your time. And there was actually a study a few years ago that really showed that at 40, 41, or at least 41 and beyond, it's really not helpful to do oral medicine and IUI because you've got kind of bigger problems with the genetic issue.
I think this is one of those situations where you really need to sit down with your reproductive endocrinologist and they need to kind of go through what are all the options, even if you don't think you're going to consider them. Sit there and listen and understand truly the pros and cons of each of those options. I mean, at the end of the day, you're the one who makes the decision as to what you are willing and capable of doing. We have lots of people who we counsel, this is what's going to give you your best chance. And so if you're in your mid 40s and you're wanting to only do Clomid, regardless of what your situation is, your chances are going to be very, very low. But it's a challenge at times.
So how long would you use Clomid or letrozole in someone who is an appropriate candidate? They come in and they've got tubes, there's sperm available, all those things, and they say we're gonna start with letrozole, we're gonna start with Clomid. How long do you go?
Well, data from the 80s, a long time ago, suggested that probably 3, maybe 4 tries is really your max. Beyond that, it's not, at least the way I counsel now. I say, we used to think maybe it would cause cancer or cause a lot of problems. We don't really think so much about that. It's just after about the 3rd or 4th month, you're probably spinning your wheels. Your success rate is going to plateau. It's additive for about 3 months, but beyond that, it's really plateaus, and you're just kind of wasting your time. And it's probably better just to move on to something that's really going to give you what you want, and that's a baby.
Yeah, 3 months is generally my guideline. And I always say that I love the phrase from Pirates of the Caribbean, when they're like, it's a guideline when they're talking about the Pirates Code, which means it is a guideline. It's something that is movable. There are going to be people who should do less than 3. Okay. And we always reevaluate each cycle, look at the things we liked, looked at the things that didn't go quite as well, and what can we do to maximize each cycle, which is another good reason not to kind of be on autopilot, just disappear for 3 months and do your own thing. But there's also, there's a handful of people who may benefit from a few more cycles, but that's on a very case by case basis. And again, sitting down and talking about what is your situation? Did you do a cycle and for some reason your partner had the flu and his sperm looked like crap that month? That might be somebody who should do one more cycle because, we didn't have good sperm exposure or something like that. So,
Or you couldn't have sex because he had the flu.
or he couldn't have sex because he had the flu. So yes, exactly. And it is a guideline, but I would say generally after 3, we're looking at cranking it up a notch.
Is there anything big, bad, and ugly that happens if you do it for 6 months or 12 months?
Frustration.
Yeah, frustration's the big thing.
Yeah, the frustration factor in all these cycles is real because when you think, oh, I've got, I know I've gotten an egg and that's the one thing that's been standing in our way. Well, why haven't I gotten pregnant? That's the time when people sometimes disappear because they're frustrated and they're annoyed, and then they come back when they're 42, and then we all of a sudden have a much bigger problem to deal with. So that frustration factor is a very legit side effect.
Well, and the one other point I want to make, and this kind of pairs with what Susan was saying about the goal is really to get you back up to where, or close to where your natural fecundity or ability to get pregnant within a month would be. I know we've all had patients like this that maybe do 1 or 2 cycles of oral medicine and IUI, and they're just so frustrated, and they're like, I don't understand. Everything was perfect. The egg was good. I got the trigger shot. The sperm looked good. The timing was perfect. Why did I not get pregnant? And I always say, well, even best case scenario with one try, 90% chance you're not going to get pregnant. And that's just human reproduction. It's just inefficient. It doesn't work well. And I think patients really think, well, we've covered all the bases, so why hasn't it worked? And the other thing I always say is there's so many things that have to happen for an egg and a sperm to go together. This really just touches the tip of the iceberg in terms of things that we know are really important. There's probably a lot of other things that we don't know about that are really important that we don't have tests for. And unfortunately, those may be some of the problems with reproduction.
What are the things you can add on to Clomid and letrozole cycles besides just the straight Clomid and letrozole that can help increase their effectiveness?
So I often use, I tend to use letrozole. I don't use Clomid really at all anymore. So I often use like a single injection of a gonadotropin about 2 days after they do the oral medication to kind of boost the effectiveness. I find that it helps boost up my pregnancy rates a little bit, and really minimal with that very small dose of the injectables, that it helps improve the response of how the ovaries and uterine lining look.
So Ovidril is another thing. So when patients come in, I always say you're probably going to ovulate today, tomorrow, the next day if your egg looks ready today, but we don't know when you're going to ovulate. So if we only have kind of one shot at it, we probably want to trigger with Ovidril, or some sort of trigger medicine, HCG medicine, to basically time when your partner is going to collect or when we're going to thaw your donor sperm and when we're going to do the IUI. So it just helps with the timing. The other thing is metformin. In and of itself, we know it doesn't work great for ovulation, but sometimes when it's paired with some of these other medications, if you have insulin resistance or prediabetes, it can affect the ability to work and really affect the ability for you to ovulate in a much better way. So not everybody, but for some people that do have prediabetes, metformin can also be helpful for them as well.
So for people who have ovulation issues, kind of an older thing that I tend not to use, sometimes people use steroids in combination with these medications. The problem with this is those steroids often drive up blood sugars, and a lot of our people who are in ovulatory already have blood sugar issues. So it's not something that I regularly use, but also using inositols, like Ovasitol or something like that, can be very helpful. We find that using that type of supplement can make your ovaries more accepting and responsive
Mhm.
to the medications we're using to help ovulation or follicular recruitment to occur. So that I think is one of the biggest things that I use nowadays is Ovasitol to improve that response.
And we have a whole episode on that as well, right? Which is
We
a really
do.
interesting episode. In fact, I'd like to go back and listen to that because chiroinositol versus,
Mayo.
yeah,
Myo. Yep.
yeah,
Yep. The split of how all that works and what
yeah.
the balance is. And yeah. Okay. All right. Well, thank you so much to our listeners for joining us for this episode. Make sure you join us next week for more. Be sure to subscribe, leave a review in Apple Podcasts. We're on Instagram, we're on Facebook, we're on YouTube. So stop by, say hello, and leave us a like or a follow. We'd love to hear from you.
You can also visit us on fertilitydocs.com to submit specific questions. Don't forget, we're writing an IVF book, so we'd love your insight into what we should put in our book. Also, we answer our questions for Ask the Docs section. So send us a question. We'd love to hear from you.
As always, this podcast is intended for entertainment and not a substitute for medical advice from your own physician. We'll talk to you soon. Bye.
Bye.